To our latest installment of T-CAIREM trainee rounds. Today, I'm very excited by the speakers we have for you. We have two brilliant researchers here to present, Brianne Laverty and Dr. Christopher Noel. So they'll both be presenting, and following their presentations, we'll open the floor up to questions, which you can put either in the chat or you can raise your hand and we'll call on you. So with that, let's get started. I'd like to begin by introducing Brianne Laverty. Brianne is a second-year PhD student in computational genomics at the University of Toronto. She completed her Bachelor of Science in Math and Biology at McMaster and enjoys using the logical structure of math to understand complex biological problems. She is currently in Dr. David Malcolm's lab studying the germline somatic interaction in the context of Li-Fraumeni syndrome. And she'll be presenting a talk entitled A Machine Learning Model to Diagnose Li-Fraumeni Syndrome from the Tumour Genome. So take it away, Brianne.
So hi, everyone. Thank you for joining me today. I'm Brianne. I'm a PhD candidate in David Malcolm's lab at the University of Toronto and Sick Kids Hospital. And today I'll be discussing my project to create a machine learning model to diagnose a cancer predisposition syndrome. So my project harnesses the power of precision oncology, which is an emerging approach to healthcare where clinicians take into account personalized traits to better guide patient treatment. So this includes things such as imaging data, lifestyle factors, and tumor sequencing. I'm particularly interested in tumor sequencing, which has many clinical utilities, such as determining the optimal treatment for a patient, subtyping their tumors, or predicting their survival. Because of this valuability, many institutions have implemented large-scale sequencing programs where every patient has their tumor sequenced. We would like to use this information to attempt to diagnose cancer predisposition syndromes using these tumor genomes. We hypothesize that individuals with cancer predispositions develop unique tumors that then we can use their sequences to better identify them. The particular predisposition that our lab studies is Li-Fraumeni syndrome, which is a hereditary cancer predisposition syndrome caused by germline TP53 mutations. It's estimated to occur in 1 in 5,000 individuals, and these individuals have a very high risk of developing multiple different primary tumors throughout their lifetime. You can see on the far right that the tumors that they can develop range throughout the body, and they can develop tumors at any age. So it makes it very difficult to diagnose this disease. And many survivors will develop additional primary tumors in their life. So therefore, it's really important to diagnose these individuals and enter them into surveillance programs so that we can detect their tumors earlier. Here I'm showing the overall survival on the y-axis and the time since diagnosis of cancer on the x-axis of individuals with LFS. We have two groups, those that were under surveillance in red and not under surveillance in blue. We can clearly see those that were under surveillance had a greater overall survival because their tumors were caught earlier, so they were able to receive earlier treatment. So therefore, it's very important to identify these individuals so that they can undergo surveillance. So currently, the majority of LFS patients are identified with clinical criteria, such as family history, tumor type, their age of diagnosis, and whether they've developed multiple primary tumors. However, 25% of individuals don't meet this clinical criteria. So we would like to find another way to identify them, and that's why we're looking at their tumor genomes. As I previously mentioned, many institutions have implemented sequencing programs where every patient has their tumor sequenced because it can help them predict the best treatment for them and their prognosis with various computational tools. So we would like to create an additional computational tool to predict whether individuals have Li-Fraumeni syndrome. Therefore, our model will fit easily into the current clinical care protocols as we're using tumor sequences that are already being collected. So overall, I'm creating a machine learning tool to diagnose pediatric LFS using genomic features. Our data set consists of 245 samples, 51 of which have Li-Fraumeni syndrome. Almost all of our samples come from Sick Kids, which is a pediatric institution. So all of our samples are below 25 years of age. Here I'm just showing the clinical characteristics of our LFS samples with their age of diagnosis on the x-axis and the number of tumors on the y-axis, with the different colors representing the different tumor types. We see a bimodal age of distribution in this graph, with many individuals developing adrenocortical carcinomas before the age of 5, and then in their teen years developing osteosarcomas and blood cancers. And this is typical of Li-Fraumeni syndrome. Although we don't have ethnicity data at this time, many of our samples of our LFS patients come from Toronto, which we know is an ethnically diverse city. And many of the samples come from patients of my supervisor, Dr. David Malkin, who has reported that they range in ethnicity. So overall, we can say that our data set represents pediatric LFS very well. I performed UMAP to visualize our data set, and we have our control samples in green and the LFS samples in pink. And we can see that there is some signal that's able to differentiate these two populations. So this encouraged us to pursue a machine learning model. We started with whole genome sequencing data from tumors, and then we used various computational tools to extract different genomic features. And these features represent different mutations and structural rearrangements that have occurred in these genomes. This is just a simplified version of our input matrix, where we have our samples, and then we have different columns for mutations. So here, C has been mutated to an A, and this base pair is surrounded by 2 additional A base pairs. And there's 96 different combinations of these trinucleotides. We also have counts for the number of structural rearrangements that have occurred in each genome. So here the one is just, or sorry, each chromosome. The one is just for chromosome 1. And then we also have different tests for massive genomic rearrangement in each chromosome. So again, the one is just chromosome 1. We removed cases with missing data, and then we trained 4 different machine learning models on our training set, which was 70% of our data, using 5-fold cross-validation. And then we tested the model on 30% of our data. Overall, we had 284 features. During 5-fold cross-validation, we performed 3 pre-processing steps: normalization, dimensionality reduction, and oversampling. We performed these only on the training set to prevent data leakage. And the parameters from normalization were applied to the test set, and then the test set was also transformed to the principal components found with dimensionality reduction on the training set. And then, of course, we only performed oversampling on the training set and not the test set. Each of these pre-processing steps were also tuned in the method used. After pre-processing of the training data, the models were built and the hyperparameters were tuned using a grid search method. We optimized the F1 score to pick the best parameters, and we chose the F1 score because it takes into account precision and recall, which are both important metrics for this particular problem. And I'll describe that why later in the results. So we refit the best parameters on the entire training set and then compared the models on the remaining test set using 6 different machine learning metrics. Importantly, we used area under the precision recall curve as opposed to area under the receiver operating curve because our data set is imbalanced. So overall, we used features from tumor genomes. We created 4 machine learning models: a regularized logistic regression model, a random forest model, a support vector machine, and a gradient boosted tree model. And these were each supervised binary predictive models where the labels were either positive or negative for a Li-Fraumeni syndrome diagnosis. We evaluated the characteristics of our training and test sets to ensure that they had equal distribution. So on the left in the bar graphs, I'm showing the cancer type distribution of our training set on the top and the test set on the bottom, with a proportion of cancer types on the x-axis and the cancers on the y-axis. And we can see between the two sets, we have an equal distribution of the tumor types, with brain and sarcomas making up a majority of our tumors. And on the table on the right-hand side, we have some other characteristics. And we can see that the training and test sets are similar between the institutions that the samples arise from, their average age of diagnosis, their sex, and their label. So overall, we did not detect any bias between the two sets. So we trained 4 different models, and here I'm using a heat map to show their performance across different metrics. We have our 6 metrics on the x-axis and then the different models on the y-axis. From top to bottom, the models are regularized logistic regression, support vector machine, random forest, and gradient boosted tree. We can see that across all of the metrics, the logistic regression model performed the same or better than all of the other models, and by quite a substantial amount. So looking at the area under the precision recall curve, a logistic regression performed much better than all of the other areas. So moving forward, that's the model that we'll be working with. Looking closer at this model, we have a precision of 92%, meaning that of those that test positive with the model, 92% will actually have Li-Fraumeni syndrome. This is very important for this particular problem. So we want to limit false positives because a diagnosis of LFS comes with extreme psychological distress, as well as burden on the healthcare system for surveilling these individuals multiple times a year for cancer. Our sensitivity is 73%, meaning that we're able to detect 73% of individuals that actually have Li-Fraumeni syndrome, which is quite exciting considering that we have a very small sample size and it's a very heterogeneous disease. On the left, we have our confusion matrix, and we see we have 5 misclassified samples in total. So we took a closer look at these samples to see if we're currently missing a subset of patients. Our misclassified samples range across the different cancer types. They also have a similar age of diagnosis to the test set, similar sex, and similar distribution in the institution that they arise from. So we didn't identify any particular bias in our misclassified samples, which is really good as it means we're not consistently missing a subgroup of patients. And finally, we looked at the feature importance of our model using SHAP to see if the features that our model was identifying as important actually made biological sense. Here I'm showing the top 15 most important features with the most important at the top. And I've highlighted 2 to discuss. TP53 minor copy number is known to be low in LFS patients, reflected here, and higher in individuals without LFS. So it's encouraging to see that this is also reflected in our model. We also know that TP53 minor copy number is very different between LFS and non-LFS patients, and it's one of the defining features of LFS. And our model has identified it as the 3rd most important feature, so it also feels that it's very important. I've also highlighted ploidy, where LFS individuals are known to be hyperdiploid, which is also reflected in this graph. So overall, it's very encouraging to see that our model is identifying biologically relevant features. These other features that the model has identified as important are regions of the genome that have experienced massive rearrangement. And this gives us other areas to look into for our future research to further understand this disease. So our next steps include increasing our sample size of LFS patients. Because this is a very heterogeneous disease, we obviously would like to obtain as many samples as possible. However, it's very difficult to get these samples because it's a rare disease and we need tumor tissue. But we found some collaborators in Europe, and hopefully these additional samples will not only increase our sensitivity, but they'll also provide us with samples from another continent. which will be good for our generalizability. We also plan to add a fully external validation set, and we found a collaborator in Philadelphia that has LFS and normal pediatric tumors. And this will be important to assess our generalizability from another institution. As I also mentioned, we would like to perform an ethnicity analysis to rule out that source of bias in our model. And we would like to perform an ablation study to further understand how our features are contributing to the model predictions. And lastly, we would like to investigate the genomic regions that our model has identified as important to further understand LFS. So overall, we've created a regularized logistic regression model with tumor genomes to identify pediatric Li-Fraumeni syndrome. Our model performs with excellent precision and recall, and the explanations make biological sense and provide us with some future areas of research. And we're working on obtaining an external validation set to confirm the generalizability. So ultimately, this project will help improve the survival of LFS patients. Because they have a high risk of cancer, they need to be identified so that they can enter cancer surveillance programs. This model is also really important because it can be easily implemented into the current clinical care protocols because we're using tumor genomes that are already being collected at large-scale institutions. It's also novel because it's the first machine learning model to diagnose a cancer predisposition syndrome using the tumor genome. So it acts as a proof of concept study that can further be expanded to other cancer predispositions to ultimately improve the survival of patients with a high risk of cancer. And thank you all for coming and listening today. I'd like to thank my lab, especially Vali Sebastri, my supervisor, David Malkin, my committee, and our funding sources.
Thank you so much, Brianne. Amazing talk. So now we are going to open the floor to questions. If anyone has any questions, please feel free to raise your hand or place them in the chat. And maybe while we wait to see if anyone has a question, Sujay, go ahead.
Hey, really enjoyed your talk and really cool project. I was wondering about, I noticed that you excluded some data that was missing, and I was wondering how much approximately of the data was missing and if you think there were any common reasons for missing this or why some of the data was missing, perhaps.
So it was just a few samples where our pre-processing pipeline kept failing, so we couldn't extract all of the features that were necessary for our input. And that's one other thing I need to do is go look back and identify why those few samples are failing. I suspect that they had really massive rearrangements and it was just timing out in running those pipelines. And also I didn't write the pipeline so to extract these features. So I didn't really have time to go into it in detail, but that's definitely something that we need to do in the future.
Cool. And then one more quick question. With your SHAP value importance features, were there any features that surprised you or anything that you guys didn't expect to see on that list?
Yeah. So it's just surprising that a lot of these really important features are to do with chromothripsis, in particular genomes. We know that chromothripsis as a whole is important to LFS, but it's never really been looked at if it's localized in different regions. So that's definitely an area that we want to look into more, as why these particular regions are popping up is very important.
Great, thank you.
Andy?
Hi, Brianne, great talk. I just have a quick question about your feature selection. And so here you're using, the whole genome and mutational signatures and such. But since LFS is defined by germline p53 mutations, couldn't you just call mutations in p53 and look for ones that have really high variant allele frequency? Like, would using p53 gene specific mutations as your features, would that enable better classification than using the whole genome?
Yeah, so one of the reasons I didn't get into it because it was just a lot of background, but about 30% of LFS patients actually don't have a germline TP53 mutation. So another important area of application for this project is to identify those individuals that don't have that mutation, and there's a known cause for their disease, but they have very similar clinical features to Li-Fraumeni, and that's why they're still lumped together. So that's why we didn't want to focus too much on the TP53 gene.
Makes sense. Thanks so much.
Okay, and I just have one quick question of my own. Can you postulate why was your least complex model that performed the best between the four?
Yeah, I was also trying to think of that as well. And I'm not really sure. Maybe because we used PCA to reduce the dimensions of the data, and those are finding linear combinations in the data as opposed to nonlinear, and this is a linear model, but I'm really not sure, and that's something that we need to look into more as well. But it is surprising.
Fair enough. All right, unless there's any further questions, I'd like to thank Brianne once more for her presentation. And now we'll proceed to Dr. Christopher Noel. So Dr. Noel is a PGY3 resident in the Department of Otolaryngology, Head and Neck Surgery at U of T. He received his MD from U of T in 2016, and from 2019 to 2022, he completed during his residency a PhD in clinical epidemiology and healthcare research. His doctoral work centered on enhancing Cancer Care Ontario's standardized symptom assessment care pathways. He has an established research track with a very impressive over 60 peer-reviewed publications and more than $1.5 million in scholarships and grant funding. And his work has been published in several leading medical journals, including Journal of Clinical Oncology, JAMA Oncology, JNCCN, and Cancer. And with that, take it away, Christopher.
Thanks very much. You guys can see my slides. Oh, perfect. So no, it's great to have the opportunity to present today. And this was actually my comprehensive project in my PhD. So I'm happy to kind of share this and get all of your input. I just want to start with a land acknowledgement. My research was conducted in a place that has been and continues to be home to many Indigenous people, and I'm grateful to have had the opportunity to work and learn on this land. I have no conflicts of interest. I'm sure that everyone on this call can appreciate that a cancer diagnosis is a devastating life event. Surgery, radiation, and chemotherapy are mainstays of treatment. And these carry a whole host of toxicities for patients. Now, when we apply these treatment modalities to the head and neck, the burden of cancer therapy is often enhanced. Patients with head and neck cancer are faced with things like disfiguring surgeries, radiation burns, mucositis, and ongoing speech and swallowing issues. As head and neck surgeons and as oncologists, we all recognize the importance of alleviating treatment-related toxicities. And yet, cancer care is primarily delivered in an outpatient setting, and supporting patients remotely while they're at home can be challenging. Too often, our patients end up in the emergency room. 1 in 3 head and neck patients will have at least one ED event during the course of their treatment in Ontario. This is the highest rate of any major cancer site, and also some of the highest rates of emergency department use in the world. And it's a problem. These events are not patient-centered. They're costly to the healthcare system. And invariably, they often precipitate treatment interruptions and reduce our ability for oncologic control. This has led many in oncology to ask the question, can we predict and prevent emergency department use in cancer care? This is a hot topic, I would say, in the applied machine learning space. There have been literally dozens of models predicting ED use in cancer care that have been developed. Some have even been embedded within electronic health records so that clinicians can identify high-risk cancer patients, provide them with additional resources, and prevent the ED event from ever happening. It may sound far-fetched, but this workflow already exists in some US cancer centers, and it's even supported by level 1 evidence. These models are not perfect, though. There are two issues. First, really, is the very modest predictive performance. I am talking about C statistics in the 0.6 to 0.7 range for the majority of cases. The second issue, and I think this is an even bigger issue, is the use of non-modifiable features. If you look under the hoods of these models and what they're using to make their predictions, it's things like age, comorbidity burden, cancer stage. We can't change these things, though. I think for a predictive model to be impactful in the real world, it needs to include modifiable risk factors with actionable targets. So this is where I think Ontario can really fill an important knowledge gap. Ontario is a very unique place in that all of our cancer centers routinely administer the Edmonton Symptom Assessment System, or ESAS. And this is a questionnaire. It's a patient-reported outcome that asks about 9 common cancer symptoms. Patients typically complete this in the waiting room before seeing their physician, and then the clinician is then given the information to review. At ICS, we have access to every ESAS score that has ever been completed. And our group has shown that this information is prognostic and immensely valuable. This is a figure from my PhD, and it shows a strong dose-response relationship between the score a patient provides on the ESAS and their risk of future ED use over the next 2 weeks. More importantly, though, the ESAS symptom data is actionable. You know, pain, fatigue, nausea, depression. We have evidence-based interventions for all of these things. The issue is that in the real world, we're not good at consistently offering these supports. About half of Ontario's oncologists do not review their ESAS routinely, and the effect of this is pretty striking. 1 in 3 high pain scores is not acted on. Less than a fifth of patients reporting moderate to severe depression receive any kind of support. So as a group, we kind of wondered whether machine learning might offer, a path forward in this case. Could the development of an ED prediction tool powered by symptom severity data help us to flag high-risk patients so that we can promptly address their symptoms and keep them out of the emergency room? So I guess with that context, our goal was to develop and validate a machine learning tool that can predict subsequent 14-day emergency department use and unplanned hospitalization in head and neck cancer patients. We followed a classic stepwise approach to model development. In terms of our cohort, this was a population-based study done at the ICS and included all Ontario head and neck cancer patients diagnosed between 2007 and 2017. For each patient, we started at date of diagnosis. We looked forward in time to last follow-up. We collected all ESAS assessments, and if there were multiple within the same 2-week interval, we selected the one with the highest score, and we used that as our anchor point, looking forward in time for our outcome of interest. Our cohort included 11,000 patients, completing 70,000 ESAS assessments and experiencing over 5,000 emergency department events. In terms of our feature space, we included the 9 ESAS symptoms, along with 36 other features related to patient demographics and treatment characteristics. And we were very intentional with the selection of our features. We wanted things that were really only available to and already routinely collected at all Ontario cancer centers. We employed, I think, several standard data pre-processing techniques. I think fortunately, I'm very privileged to work with ICS data because we have complete data in the majority of cases, and honestly, this process was fairly straightforward. In terms of model development, our analysis was at the ESAS level, with 80% of observations used for model training, 20% set aside for test. Within the trained data set, we used a 5-fold cross-validation procedure to tune our hyperparameters and optimize the learning environment. We explored 5 different machine learning algorithms. Many of these are the workhorses of supervised classification, and I think this audience is probably very familiar with all of them. Truthfully, though, I'm actually more used to presenting to a lay clinical audience, where a lot of these algorithms are still a little bit foreign. So I've previously created infographics to try and explain the mechanics of each one at a very high level. I think it's useful for physicians to know because this really is the future. So I thought I'd still include them and kind of get your guys' feedback. So logistic regression, I think, really needs no introduction. Almost, I think all physicians are very familiar with that classic sigmoid shaped curve. Its power coming from the fact that it can be transformed into a linear equation, which then generates those odds ratios that we all love. Now, I think most clinicians are used to logistic regression in the context of causal inference. Risk prediction is a little bit of a different beast. There needs to usually be some, often I think a full model won't generalize well to new data, and there needs to be some form of variable reduction. We used lasso for what it's worth. And I think the other challenge is the nonlinear relationships. They need to be explicitly defined by the user as opposed to some of the other ML algorithms. So I think to give logistic regression a fair shake, so to speak, we did expand the feature space to include select two-way interactions and polynomial terms that were guided sort of a priori based on clinical reasoning. K-nearest neighbors works by storing training data in a multi-dimensional feature space. I think it's a very elegant algorithm, and it classifies new data points based off the proximity of its nearest neighbors. Random forest and gradient boosting machines are both ensemble tree methods, and they're kind of based off this principle that multiple weak learners can make accurate predictions when working together as an ensemble. So random forest sort of achieves this by first generating thousands of artificial data sets through bootstrapping methods. Within each bootstrap sample, a decision tree is built. Each tree casts a vote, and the outcome with the most votes wins. Gradient boosting is very similar, but instead of building the models in parallel, they're built sequentially, one at a time, with each model learning from its predecessor's mistakes. And finally, the neural nets. This model consists of a series of nodes arranged as an input layer, an output layer, or one or more hidden layers. And it's that hidden layer that's key in that it allows for the modeling of complex nonlinear relationships. So again, the purpose of our five-fold cross-validation procedure was to define our hyperparameters and optimize learning environment. I did this all in R using care package, and they don't pay me, but I cannot sing their praises enough. I am a very simple surgeon. I don't have a computer science or math background. I did learn how to code a little bit during my PhD, but I just really appreciate how accessible care it is. It's kind of this one-stop solution, and you have sort of hundreds of different models you can pick from and has that common syntax. So I did a randomized grid search, and really Carrot, I think, helps automate the selection of your search space, tells you which hyperparameters to explore, and sort of sets the defaults for the less important ones. The only reason I show you this file is just to give you a sense that the optimal parameters weren't on the edges, which is a good thing. So once we defined our hyperparameters, we then use a full data set to fit our final models and make predictions on our out-of-sample test cohort. For our primary outcome, we tracked the area under the receiver operator curve. Again, I think everyone in this audience is very familiar with these plots, but the goal is to hug that top left corner as much as possible. And you can see that all models generated C statistics within 3 percentage points of each other. And the gradient boosting machine emerged as the winner, C statistic of 80%. I think for an ED prediction tool, this is a very strong performing model. Now, I did define an optimal cutoff point and reported sensitivity and specificity, and that was just a statistically derived threshold using the Udin's J. Though, of course, I think that threshold could be varied and the tool made more sensitive or specific based on your sort of institution's resources. We also assessed model calibration, and you can see for our gradient boosting machine, it nicely hugs that 45-degree orange line representing a perfectly calibrated model. We also wanted to get a sense of how much our models relied on the ESAS scores to make their predictions. I think everyone knows that sort of here that the gradient boosting machine is in that realm of black box models, so it's a slightly more difficult task. I also produced that SHAP summary plot. This is not that common, I would say, in ClinEpi, so it was sort of fun to explore this. I had the figure and like the math powers, it's quite complex, but you can see that the top 10 features are rank ordered, and that our ESAS symptom data occupies 5 of the top 10 spots. To get a sense of the relative importance of ESAS, we also built a second model using the ESAS symptom data and nothing else, no other features. And you can see that that model generates a C-statistics on the test score of 0.72. I think it's another way of approaching it and just highlights the significant predictive power of symptom scores. So in bringing it all together, I do think this model has fairly strong performance. More importantly, though, it's populated with things that are actionable and that we can actually intervene on and change to attenuate someone's risk. And I really think that's the most important aspect of this work. Obviously, there are many limitations to what I did, and this is a series on AI and machine learning, so I think it's important to touch on those. I think the biggest issue, and this came up a lot in peer review, was that our data set does not perfectly mimic the real world. So our data structure, the way we did it, we used the ESAS as the anchor point, and we looked forward in time with a fixed observation window. A quarter of our ESAS assessments were dropped, though, to avoid overlapping observation windows at the patient level. I think that's fine for causal inference, but it is a bit of an issue in risk prediction. I truthfully don't think it substantially changed sort of the model's performance. I randomly sampled sort of one ESAS assessment per patient and redid everything, and I got a very similar answer. But there are other modeling approaches that would have allowed us to incorporate all the ESAS observations. Our model does not account for individual level correlation, and sort of whether this is a significant issue or not, I think is an area of future research for our group. And then there is, I think, a question about whether the performance could be improved with more granular treatment information, vital signs, exact timing of chemo and targeted agents, and cumulative dose of radiation. The reality is we just don't have access to this at the ICES as of yet. So this study is in press at JAMA Otolaryngology, head and neck surgery, and it's kind of coming out in a few weeks. So you guys got a bit of a sneak peek today. I actually want to thank the editor-in-chief who made an exception to the embargo so that I could still share my work with you today. This project also uses PUM data for Canadian Cancer Society Challenge Grant, which was funded, and I'm excited for the future because of that. I think we're using some of that resource to try and take our AI tool out of ICS and integrate it into our EMRs. I'm under no illusion that there's a big leap from in silico to the real world, but I do think the potential is there. I really think there's a lot of value in being able to accurately risk stratify patients in real time and direct limited resources to those most in need. Things like biweekly in-person symptom review, dedicated nurse navigator team, and real-time symptom monitoring. In a public healthcare system, we could not offer this level of resource to everyone, but it is very achievable in a subset. And it's just one of 4 strategies being explored by our group to strengthen our outpatient symptom management care pathways. And I really think it's these kind of innovations that will move the needle forward for our patients. So that's it for me. I just want to close by acknowledging all the granting agencies and scholarships that supported me over the last 3 years, my thesis committee, as well as all the faculty, staff, and colleagues that supported me in this project. If I have gotten anywhere, it is because of them. Thank you, and I'm happy to take any questions.
Thank you so much, Chris. Really interesting seeing the integration of really fundamental symptomatology regarding pain, depression, fatigue into the sort of prediction model that you presented here. So I'll start with a question from Benjamin.
Very, very nice work, Christopher. Very didactic. 2 quick questions. So when you split into training and test set, do you do it randomly? Do you check whether the distribution is the same, or even probably better, do you take your latest observations to kind of reflect how the model would perform in the future if there is a data shift?
I did it at the patient level so that patients couldn't contribute to both. And it was randomly done. But no, I didn't actually include that temporality where sort of the later patients were set aside for tests. Truthfully, it was just a random split. But that is a good point.
Yeah, you could have a shift in the distribution of the data. And then the other question is, what's the class imbalance for that prediction model? Use logistics, so I suppose
Yeah, we had a 7% event rate. So I talked to Rinku, who is my go-to statistician, about she's all knowing. And she told me it was okay and I didn't need to oversample. She thought that was sufficient, but it was a 7% event rate.
Yeah, ROC can be a little bit overly optimistic when there is such a huge class imbalance. So we use other performance metrics. If you look at the previous presentation, there was a
I saw
matrix, and that's kind of useful when you have class imbalance that way. Thank you.
Simple surgeon, but no, it's a very good point. Very good point.
Sujay?
Yeah, a really good talk. I especially liked your brief tutorials on the different algorithms. I thought those were really well done. So I had a question about your thresholds for your model, and you talked a little bit about balancing sensitivity and specificity. And my question for you is, what would you as a surgeon want to optimize for in a clinical deployment setting? And like, what are the risks and rewards of a highly sensitive model versus a highly specific model in this case?
Well, I just think it really depends on where you're deploying this, right? And the level of resource that we have to support patients. You know, if we really, you know, want to catch everyone and make the tool very sensitive, that's great, but it will require a lot of nursing. It will require a lot of allied health that just many of our unfortunately, our publicly funded healthcare systems can't support. So I think that threshold is going to vary depending whether you're in Canada or the US, or just really the level of resource that you have. Like, do you really want to target people that are like a very highly specific cohort where you know that these people are truly high risk? Or are you well resourced and you can maybe offer more people an enhanced protocol? I think it's very institution specific, but it is. I think that's why I almost regretted doing the Udens J, to be honest, because I think people sort of see the sensitivity and specificity and think that that's it, but it obviously varies depending on your circumstance and what's available at your cancer center.
And then my next question, it's the same thing that I asked the last presenter. For your SHAP value explanations, was there anything that surprised you?
No, I can go back to it, but you know, I think the reason ED risk has failed, like we haven't generated very accurate models, is we are focusing on the wrong things. We're looking at, like, we're used to predicting mortality and other things in oncology, and we know age, comorbidity burden, that, you know, those are all very accurate cancer stage. Here, let me find it. Whereas I think ED use is a very different game, and what drives people to the emergency department is very different than what a lot of the things we classically measure in ClinEpi and we have access to. And you see that reflected in this, right? It's home care use. It's the number of ED events you've had in the past 30 days in the year. And, you know, a lot of your symptomatology, you know, is being captured in that. It reminds me a little bit of William Osler. He has that very famous saying, like, if you listen to the patient, they will tell you the diagnosis. Like, I think our patients tell us when they're struggling every time they complete the ESAS. And we have an obligation to review and act on that information.
Thank you so much.
Any other questions from the audience? I see one in the chat. So this question is from Junaid. He says, thanks for the talk, Dr. Noel. I was wondering, how were you able to pick up machine learning algorithms for your PhD project? Did you have experience with such algorithms before?
Oh, you know, ClinEpi is not bad. Like, they have coursework on it, so you do get some exposure. I honestly, there's so many resources online, like Data Camp. Like, if you use the Carrot package, for instance, there's so many tutorials just how to use it that I was able to make it work. But I think the IHP-Me and ClinEpi is doing a good job at trying to get us more familiar with these, because I really think they're the future. But obviously I would say I don't have the same level of knowledge as obviously the computer scientists and you know, the true machine learning experts that I think are driving a lot of the innovation in this space. But ClinEpi is doing a good job at making applied ML kind of accessible to their students so that they can kind of play around with it like I did.
Okay, any final questions? If not, I'd like to thank both of our speakers once again for 2 incredible talks. Thank you so much, Chris and Brianne.
Thank you.
And before we say bye for today, just 2 quick announcements for summer research students who are in attendance at this talk right now. So just notifications of 2 events of note coming up on June 17. That's this Friday. There is a skills session hosted by the DSI. And on Monday, June 20th, we have a professional development session with Dr. Melissa McCradden. That's now at 1 p.m. So just take note of that time change. And with that, I'd like to thank our speakers one last time and hope everyone has a great day. Thank you.